So welcome everyone. My name is Grant Martzoff. I am a professor at the University of Pittsburgh and the director of our health services, nursing health services and policy research hub, which is a group of researchers with similar interests. Obviously, this particularly around health services and policy research. Our dean gives us a little bit of money to create some infrastructure to bring researchers together. We have a number of activities, but one of them is this twice monthly research colloquium, which has been quite successful. We've brought in a lot of really interesting researchers, both internally and then externally to the university, both within the nursing school and then outside the nursing school as well. So from looking at the folks on the call, it looks like we have quite a few. Well, we have almost 20 people. I was going to say we should introduce ourselves, but now that we're close to 20, I think that might take a little bit too long. But I just want to welcome everyone from the University of Delaware. It's really great to have you on the call. I'll do a quick introduction. So Hillary Barnes is an assistant professor at the University of Delaware School of Nursing. Her PhD is from Practitioner University, as well as her master's degree at family nurse practitioner. She did a postdoc at the University of Pennsylvania in the Center for Health Outcomes and Policy Research with Linda Aiken, who many of you might know is in many ways the pioneer of nursing health services and policy research. And many of us have, in some ways, who are in this field, have been connected with Linda in some way. So Hillary was a postdoc there. I met Hillary many years ago at a group called Interdisciplinary Research Group for Nursing Issues, which is an interest group at Academy Health, which is the major national health services research professional association. And ERGNI, which we call that interest group, is very active and very large and is really the epicenter of nursing health services research. And Hillary and I also worked together last summer to organize a national meeting of 40 nursing health services research scholars to develop a plan and a goal for the next 10 years in terms of the important questions in health services research. That was a really good opportunity for us to work together. So without further ado, I'll go ahead and pass it over to Hillary. Hillary, do you want to be interrupted with questions or do you want to save to the end? It's totally up to you.
Either's fine. Yeah, I don't mind being interrupted.
Okay.
Or you can save them to the end. I also have the chat open here, so if somebody has a question, you could throw it up in the chat and I'll try to kind of glance over there throughout the presentation.
Awesome, great. And one other thing to mention too is, these talks range from career retrospectives to a finished paper that's going to be presented to works in progress. So you can consider this as something that you receive as a presentation, but at the same time, also it can be a working presentation for the presenter to get feedback. And I assume, Hillary, this is sort of more of your what we're looking at right now is sort of work in progress, to get feedback and look forward. Is that right?
Yeah. Yes. This is the kind of the pilot study, the first step in this instrument development I've been working on.
Awesome. All right. Well, thanks so much. We'll go ahead and get started. And
Okay,
please mute your lines if you're not speaking, and it looks like most are. So, all right, go ahead.
Okay, thanks, Grant, and thank you everybody for joining this morning. It's great to see 21 people on the call. So I am going, like I said, I'm going to be presenting the pilot study phase of an instrument I've been developing to test or to study novice nurse practitioner role transition. I first want to acknowledge my co-authors, Dr. Asifeh Faraz-Kavelli, who is a nurse practitioner and a researcher at the George Washington University School of Nursing. And this work kind of came out of our own independent programs of research on nurse practitioner role transition. I worked on it when I was a doctoral student at Widener, and then for her doctoral studies at Yale, she worked on it. And then once we began our faculty careers, we kind of connected and decided to join forces and move that body of research forward, because the concept and the idea of nurse practitioner role transition is becoming more and more important and critical to study. So this is kind of the beginning of that collaboration. And then I want to also thank Dr. Jonathan Rubright, who is our psychometrician on the team, who helped us with item development and guided some of the data analysis. I also want to quickly acknowledge the funding. We received 2 small pilot funding grants for this project, and I'd like to acknowledge our expert reviewers who helped us in early stages of the instrument development, as well as the American Association of Nurse Practitioners and their research team there for support in data collection. And I wasn't sure if I needed to say this, but I have no conflicts of interest. All right, so what we're seeing, so a little bit of background on why we're studying this. So the US healthcare delivery system, as we all know, has become increasingly complex. Our provider workloads are going up, they're increasing, our patient complexity is increasing, there are more patients seeking care, and we also are living through this time with this new global pandemic that's really kind of shifting around how we're delivering care, and it's increasing the stress and increasing the workload for our providers. So with all these changes and all this increased complexity, healthcare providers are really at risk for decreased well-being in delivering care. And that decreased well-being leads to poor, or potentially can lead to poor workforce outcomes, such as job dissatisfaction, intent to leave, turnover, and that can lead to poor outcomes for our patients. So discontinuity of care can lead to poor outcomes. And there's some emerging research out there showing that with poor workforce outcomes, the quality of care is diminished. And so this is important for all providers, but what we're interested in here are those providers who are in that moment where they're transitioning from one role into a new professional role. So they're really in this vulnerable point of their careers where they're moving from being a student to a provider, or they're moving from one provider role to another provider role. And this is a really vulnerable time for them where they're at higher risk for a poor transition experience, which could lead to poor workforce outcomes. So we really want to focus on those novice clinicians and look for ways to support them. And so what Dr. Faraz Covelli and I did is we joined forces to kind of collaborate on looking at nurse practitioner role transition. And we developed this conceptual framework from looking at the research, from our own, looking at the available research and from our own research efforts. We developed this conceptual framework of the domains that drive nurse practitioner role transition. These domains include educational preparedness. So this includes first, being educated as a nurse practitioner. So you need to earn your master's degree, you need to earn a DNP to become a nurse practitioner. This also includes the feeling of being prepared for practice. So having received the competencies you need to deliver care, feeling prepared that you can work as a nurse practitioner. The other domain, the second domain is role acquisition, and this is the domain of kind of embodying the role, of becoming competent in the role, of performing the tasks that are important for the role, but also it includes feeling like you belong, knowing what is expected of you, and having others understand your role so you're able to deliver care. And a subdomain underneath this is also mentorship. So having that support and that mentorship to guide you into this new professional role. The third domain is job satisfaction. So this incorporates kind of a lot of the organizational components of role transition. So this is professional autonomy. Are you able to deliver care in an autonomous fashion, or are you more restricted, or is your care more dictated, or are you really strictly supervised? How are your relationships with others in your organization or in your work setting? How are your relationships with physicians, other APNs, PAs, RNs, MAs, administration, staff, anybody else in the organization? Time to complete work is, are you able to meet the demands of your job? So can you complete the work on time? Can you meet your patient's clinical care needs? Are you bringing work home with you? It's like, are you able to meet the demands of your job? And job benefits, are you happy with your job benefits? Do you feel you're being fairly compensated? Are there other factors of the job that allow you to feel that you're being treated fairly and you're being compensated well for the job? There's also the subdomain of sense of meaning. So this is not only under this major domain of job satisfaction, we have, are you able to complete your work, right? But this sense of meaning subcomponent is more, how do you feel about it? Are you able to, do you feel like you're making a difference in your community? Are you making a difference for your patients? Do you feel like you have a sense of purpose? Do you feel that you belong in the NP role? Is it the right role for you? And then this final component that has kind of emerged into the role transition more recently is this work-life balance. So are you able to engage in activities outside of work? How are your relationships outside of work? Are you taking work home with you? to have work-life balance. So all of these domains and these subdomains kind of drive NP role transition, and these can lead to an individual having a successful transition, but they can also lead to an individual, if they're not in a positive frame, lead an individual to an unsuccessful role transition experience. And an unsuccessful role transition experience can lead to increased intent to leave, job dissatisfaction, poor well-being, and that can influence an individual's decision to stay in a role, but also to stay in the career. And so in the research, nurse practitioner role transition is not, a lot of the research is framed kind of negatively, but this could also be a really exciting time for individuals. So there's a lot of learning, there's a lot of professional growth, there's a lot of personal growth. It's been described as a really exciting time for individuals. And there's a lot of these components really facilitate that successful role transition experience. But when they're not there, and when these components are not there, or when they're not facilitating successful role transition, an unsuccessful role transition experience can be described as feeling isolated, feeling overwhelmed, feeling stressed, feeling a lack of confidence, feeling ambiguous about your role. So what we really want to do is we wanted to develop this instrument so we can measure this concept and see how it links up to different workforce outcomes. And it's important to study NP role transition because our NP workforce is growing. There's approximately 28,000 new NPs entering the workforce every year. And we need a way to support the NP workforce and their well-being to enhance care delivery and productivity. Supporting well-being is actually a component of the quadruple aim. So we're all familiar with the triple aim, lowering costs, improving the patient experience, improving population health outcomes, but we can't achieve those triple aim goals without also including provider well-being. So we think it's a really important component to study our workforce and make sure that they're doing well, and that particularly our new nurse practitioners are transitioning well into the role. We're also seeing an increase in organizational and educational interventions to support the NP workforce as they transition into this new profession, such as residencies, fellowships, and a lot of nurse practitioner programs are looking at ways to adjust their curricula to support NPs into transition. So we need a way to be able to measure the effectiveness of these interventions. And we need a way to conduct large-scale and systematic examinations of role transition and its association with NP workforce and patient outcomes. And currently, there's no instrument to do that. So what we did is we developed the Novice Nurse Practitioner Role Transition Scale. And today I'm going to describe that instrument development process, as well as our initial analyses through an exploratory factor analysis. So using the conceptual framework that we developed, combining our two programs of research, we came up with 83 items, 5 items underneath educational preparedness, 30 under role acquisition, and 48 under job satisfaction. And we weighted the number of items under role ambiguity and job satisfaction a little more because, one, we had all these subdomains under these larger domains, but also the research kind of indicates that these are the components that drive NP role transition a little bit more than the educational preparedness. So we wanted to weight the number of items on the scale that address these two larger domains. And we used a 6-point Likert scale from strongly disagree to strongly agree. So the first thing we did was to assess our face and content validity. So last year we recruited 4 experts as part of a panel to conduct an expert review, and these were individuals that we've identified as leaders in NP education, NP role transition, NP practice, and NP role transition research. We had each of the expert reviewers rate the relevance of each item to the concept of Novice Nurse Practitioner Role Transition Scale. And based on and they were also able, so they not only used this Likert scale to describe rate the relevance, they were also able to provide comments on each item. And based on the content validity index, which was a calculation of the agreement among all 4 reviewers, based on their expert comments in terms of wording or whether they felt the item was relevant or not. And based on our own conceptual understanding of the concept, we omitted, retained, and revised items. And this resulted in us removing 17 items. We then took this new set of items and we recruited 7 NP graduates from both of our institutions the next summer to just kind of test the items out on them and have them rate their importance to the concept. So using some of these same techniques, general agreement, their comments, and our conceptual understanding of the concept, we then omitted 9 more items. So then we took our 57 items and we moved on to pilot testing of the scale. So we used a cross-sectional design. We collected data over 3 months at the end of the year and the beginning of this year using a Qualtrics survey. And we recruited a convenient sample of novice nurse practitioners. Our primary data collection method was recruiting novice nurse practitioners from this AANP Career Starter membership. And their Career Starter membership is a membership that's indicated for nurse practitioners who are within their first year of practice. So we thought this would be a good way to target our data collection efforts. And so we sent 3 email blasts to a random sample of 2,000 members of the Career Starter memberships. And then to increase responses, we also used some additional snowballing efforts using our professional networks. Our inclusion criteria were working as an NP, working in your first position as an NP, working within 12 months, or working less than 12 months, and 18 and older. And we, with each email blast, we increased our incentive gift card from $10 to $25. So with our funding, we were very limited in the amount of money we had, but we're learning people don't do anything for $10. So we had to kind of increase our gift card incentives as we went through our data collection. And so the surveys we used was our nurse practitioner role transition scale. And this is our 57 items. This measures the individual's perception of their role transition experience, and higher scores indicate a more positive role transition experience. We also included a demographic survey that included personal characteristics, professional characteristics, and current employment characteristics. So in the end, we ended up with 89 usable surveys. We had more responses than that, but people either didn't consent to be in the study, so they screened out, or they screened out when they answered questions regarding the inclusion criteria. And we then, through our data cleaning processes, we included only those surveys that had complete novice nurse practitioner role transition scale items, and we removed any responses that indicated response bias. So if they were just choosing all agree or all disagree, we kind of looked at the pattern responses for each individual and removed any that looked like they maybe were, had some weird response patterns. And as you can see here, this is the breakdown of our sample. It was majority female, mean age of 38, which is a little lower than what the AANP reports for the entire NP workforce. But if these are novice NPs, they're likely a little younger, NPs entering the workforce, so weren't too surprised that the mean age was a little lower. Mostly white, mostly certified in primary care. Still, the overwhelming majority are educated with a master's degree, and almost all of our sample had at least some years of RN experience. And a few were participated in an NP residency or fellowship program, but of those who said no, over 60% received some sort of formal orientation. And that's important because formal orientation has been shown to improve the NP role transition experience. And about 33% were in private office settings and 12% were inpatient settings. So then we moved into data analysis, and I'm going to kind of talk about data analysis and the results at the same time. So the first step is in data analysis of the the instrument is to do item analysis and reliability. So we looked at the descriptives of each item. So we looked at histograms, means, medians, standard deviation, and range to kind of see how people were answering and see how the items performed. We then looked at a correlation matrix of all 57 items, and we identified highly correlated pairs, so pairs of items that were correlated at 0.85 or greater than 8.85. What this indicates is that there's redundancy among the items. So the items, if they're highly correlated, they're basically asking the same thing. So we identified 4 pairs of highly correlated items, and it turned out that 3 items were actually really highly correlated with each other. So 3 of those pairs were of the same items, and then there was an additional pair. So we removed 3 items, and and the recommendation is just to look at the items and choose which one you think better is asking what that item is measuring. So we just looked at them and then just chose one. We removed 3 items here. Our reliability for that for this original or this initial evaluation was 0.96, and then we did a leave one out analysis, which looks at looks to see if the reliability increases with the removal of any one item, and the reliability didn't increase with the removal of any one item, so we left it as is and we moved on to the next steps. Okay, so the next step is the exploratory factor analysis. We've kind of looked at our items, we looked at our reliability, and the next step is the exploratory factor analysis. And what the exploratory factor analysis is, it is a way to kind of look at what the factor structure of the instrument is. So even though we used a conceptual framework to guide our item development, the exploratory factor does not put any a priori theoretical structure on the items. It just lets the factor structure kind of emerge from the items. And we use a principal factor analysis because it's a little better for recovering weak factors, and it's also more useful when you have a small sample size, which is what we had. We ran a Kaiser-Meyer-Olkin test, which is a test of sampling adequacy, and a test of 0.6 or greater indicates that your data are adequate for conducting EFA, and our KMO test was 0.8 for these data, suggesting that the data were adequate for an EFA. So then how many factors to extract, right? We want the factors to kind of emerge from the data, but we have to tell the software about how many we think there are going to be. So there are these 5 approaches that we use to kind of give us an idea of how many factors. The first is the most common, and probably the one people are most familiar with, is the Kaiser's criteria. And what that is, it just looks at all the eigenvalues of the factors greater than 1. And this, for our data, it suggested 11 factors. But this criteria is known for overestimating the number of factors. And when we think about it as researchers, 11 seems like a lot of factors for a role condition. So we then looked at a scree plot, which is a plotted curve of all the eigenvalues. And you look to where the inflection point is, where the curve starts to flatten out, and all the factors above that inflection point is the suggested number of factors. And so that identified 5 factors. And in conjunction with the scree plot, we also did a parallel analysis, which is a analysis using simulated data. So what Stata did, I use Stata. So what Stata does is it generates, in this case, 1,000 random data sets of simulated factor analysis data using a similar number of observations and a similar number of items that we had. And it runs random data sets 1,000 times to see if that factor structure still holds, or if you, if our observed data, or if the simulated data generates a different factor structure than our observed data. And the parallel analysis indicated 5 factors as well. And then we also looked at the minimum average parcels, which looks at the intercorrelation among the factors, and that also generated a suggestion of 5 factors. And then based off of these 4 approaches, we used interpretability, which is just the researchers' kind of assessment of what's going on. So when we look at these, we say to ourselves, well, 11 factors with the Kaiser criteria seems like a lot of factors. 5 seems more doable and seems more appropriate for novice nurse practitioner role transition, so we went ahead with 5 factors. We then decided to run the EFA on 5 factors. We used an oblique rotation, which allows for the factors to correlate. And we made items on the instrument that had pattern coefficients under each factor of 0.4 or greater. And then we omitted items that had pattern coefficients of 0.4 or less on all factors, or items that double loaded on 1 or more factors at 0.32 or greater. So each time you identify items to remove and you remove the items, you have to rerun the EFA over again. So we did this iteratively 4 times and ultimately omitted 14 items. And so we ended up with this 40-item role transition scale. And our reliability for this scale was 0.96. The KMO test, the sampling adequacy test, was 0.85. The Kaiser's criteria for this group suggested 7 factors, so you can see that the number of factors has come down as we kind of removed items and cleaned up our data a little bit. And still the scree plot, parallel analysis, and the MIP is to 5 factors. And this image here is our final scree plot and the parallel analysis. So as you can see, the curve with all the gray dots is the scree plot. And where that curve kind of flattens out above that inflection point is the suggested number of factors. So you can see there are 5 factors above where it flattens out. That dotted line along the bottom is the parallel analysis. So that's the factor structure based off of our simulated data. And factors in our observed data that are above this parallel analysis line indicate true factors. So you can see that our 5 factors are above that simulated data line. So suggesting that those 5 factors are better than our observed 5-factor data or better than this simulated data. Okay, so we have this new structure of novice nurse practitioner role transition, and we have these 5 factors. One factor is organizational alignment, which is a kind of a new factor that emerged from a collection of items that pulled from other domains and subdomains from our original conceptual model. Mentorship kind of moved out onto its own. Sense of purpose kind of emerged as its own. Perceived confidence and self-confidence still remained. And compensation was part of our job benefits subdomain, but kind of pulled out on its own. And next I'm going to show you the individual items that are in each factor. So factor 1, organizational alignment. This is really not necessarily job satisfaction. It's more than job satisfaction. It's being, we're interpreting this as the NP feeling welcome and integrated into their organizational, into their organization. Are they treated like a profession? Do people understand the role? Do they understand the work that they're doing? Are they supported by their colleagues? Do they belong where they are? And it's also some job satisfaction, but it's more than just job satisfaction. It's being integrated and welcomed into the organization, and that it's a good fit for them. And there are 14 items here. You can see I'm satisfied with my benefits and I'm able to schedule time off. Those last 2 items kind of moved out from under our job benefit subdomain and into this organizational alignment. So this was an interesting factor that kind of emerged. Next factor is mentorship, and all of our mentor kind of questions hung together. And this is interesting that it pulled out by itself because we originally thought that mentorship might fall under organizational alignment or might be really tied to the organization, but having it as a separate factor kind of supports the importance of mentorship to role transition. So it's different than being an organizational fit, but it also suggests to us that maybe mentorship is not tied to the job, and that the NP might be able to find mentorship external to their organization. It also shows how important this is to role transition. The third factor is sense of purpose. So this is feeling that the work you do is important, that you're serving your patients well, that you're serving your community well, that you're you have good relationships, and that you feel like you've made the right decision and what you're doing is important. The next is perceived competence and self-confidence. And this is a little separate than sense of purpose, where you feel like you're making a difference. This is actually meeting the demands of your job. Are you able to complete your work on time? Are you able to meet the demands of the role, complete your work in a timely fashion? You're not taking it home, and you're meeting your clinical care needs for your patients. And when we're done, I'm happy to go back and show you these items again if anybody has any questions. And the final factor is compensation. So this is feeling compensated for the work you do. Some of the research has found that NPs have expressed dissatisfaction with the level of compensation after they move from the RN role to the NP role, either from moving from the RN role to the NP role, maybe getting paid less, but also inequality across their NP peers in terms of compensation. So this isn't about getting more and more money, it's about being fairly compensated for equal work. So some limitations of the data is the data self-report. So as with any self-report data, there's a potential for sampling bias. So NPs with really poor transition experiences or really awesome transition experiences might have been more inclined to respond to our survey. We did have a small sample size, and we were unable to target our emails to AANP members who met the inclusion criteria. And we also had not as much control over the timing of the emails or the title of the email, which could have not been as enticing to individuals to respond to the survey. And so we're unable to calculate our accurate response rate through combined recruitment methods of emails and snowballing. And we ended up with a small sample. So in conclusion, it's important to study novice nurse practitioner role transition because we have our growing NP workforce. NP employment is increasing across all settings, and we're having an increasing complex healthcare system, so we need to be able to support our workforce as they transition. So having an instrument to measure role transition will improve our examination of the concept across practice settings, across educational experiences and preparation, and across regulatory environments. So we expect the NP role transition scale to be useful to organizations, employers, and educators needing evidence to guide development of interventions to support the novice NPs. And so our next steps is to conduct a confirmatory factor analysis using a new sample of novice NPs, and we're in the process of securing funding for that recruitment. And what the confirmatory factor analysis is, we will use our new 5-factor structure as the theoretical framework to impose on the data as an a priori hypothesis to confirm the factor structure is what it is. And so we encourage, and we want to start encouraging use of it in future research and practice change projects and in interventions to support NPs transitioning to their new role. So thank you for your attention, and I'm happy to answer any questions or go back to any slides. Anybody? So thank you. And feel free to reach out to me if you have any questions or want any more information.
Yes, go ahead and open up the floor to any questions. You can go ahead and feel free to unmute yourself and just ask directly.
Hi, Dr. Barnes. Thank you so much for joining us with this really interesting work. I had a question about, did you know whether the people who were responding were people who were basically working at an organization because they had to as kind of a payback for tuition that they had received, and whether there was any difference in them?
We didn't ask that question, no. That is a good question, though. That would be a good question to ask on future surveys, but we didn't ask that question.
Thank you.
Yeah.
Good morning, Dr. Barnes.
Hi.
Hi, it's Haley Garamack from Pitt Nursing. Thank you so much for speaking this morning about this tool that you've been working on and really going over the development. I have a question about the level that the tool can measure at. So it seems like a lot of these questions have to do with an individual's experience. Is there any test you can perform or anything you can speak to about how much you can actually cluster this at like the facility level or the organizational level to more represent facility or organizational level experiences? Was that like part of the design intention, or could it be, or could you even test to see if it does that?
It's an interesting question. The first thing I thought of in terms of organizational level would be just to get a bunch of people from the same organization and see how their experiences. Because this is a pilot test and we had a small sample, and this is really the purpose of this was just to see what the factor structure of the instrument was. We didn't really delve into comparing groups of people or comparing different experiences. We just really wanted to see what that factor structure was. But organizational level analyses would be interesting because the factors that kind of emerge are both intrinsic and extrinsic factors. And the research has shown that there are intrinsic factors that promote and or inhibit NP role transition, and there are extrinsic factors. And so this instrument really kind of is showing that both of them are important. So you have your organization's important, but it's also like your own feelings. So I don't know, that might be something for us to talk about a little bit more, but the first thing I can think about is just getting a bunch of people in the same organization and then making a summary variable of their outcomes and seeing if like some organizations are better than others. I think I need to talk about it a little bit you and I would need to talk about it a little bit more, I think, to really flush that out.
I was just thinking about like generalizability for policy and practice implications that might be really valuable.
Yeah.
Thank you.
A more restrictive organization might make it harder for an individual, or somebody who's really isolated might be harder for them, or yeah.
This is Susan again, Hillary. The other one that to look at is, as you know, there is great call for NPs to be doing residencies like physicians do. And so I know, I think it was 8% of your sample actually had done those residencies. So I think that would be a very interesting group to track, to compare to those who are not doing residencies along the way, to see how the factors change as a result of those residencies or not, because I know that there is, we're looking for some transition to practice kind of model, but we also are trying to have organizations feel like our graduates are prepared for practice when they leave. And so we've got that push-pull thing going on right now that we're continuing to monitor.
Yeah, exactly. SFA and I talk about this all the time, that we want this instrument to start doing exactly what examining exactly what you're saying. Do people with different degrees fare better, or different types of programs fare better, or doing a residency, do they do better? So yeah, exactly. Thanks.
Hillary, it's Kathy Helferty.
Good morning.
How are you?
Good.
One of the things that people talked about in my doctoral program was, whatever you do, don't develop a tool. It sounded like the most complex and intensive work in nursing research. Can you talk about the time that you decided that the only way to move forward was to develop a tool?
Yeah, so this is something I've been thinking about for at least 7 years since I left my PhD program. Because when I did my PhD, I did my dissertation on NP role transition, and there was a doctoral student at UConn at the time who was developing an instrument, and I connected with her mentor, and they let me use the instrument. But it wasn't, like, the psychometric analyses weren't complete, and it hasn't ever moved beyond the student's dissertation. And so I used it, and I wanted to keep moving it forward, and I tried to get them to, you know, move it forward, but it just never went anywhere. So once I started my faculty position, I was like, I really want to get back into role transition. And Dr. Frau started publishing on role transition, so we connected, and I was like, you know, for us to really study this, we need to have this instrument. So it's been something I've been thinking about for a long time, and I've been wanting to get back into, so I'm really glad to be back into it. But for SFA and I, it's been a couple years of item development and a lot of meetings and the expert analysis, and then getting some funding so we can do some data collection. So it's been a long time, but I think it was definitely, it's an important thing to, it's an important tool we needed as more and more people are looking to study role transition.
I agree with you wholeheartedly.
There's nothing out there right now, right?
Right, yep.
And if we're going to keep growing these residency programs, or we're going to keep changing our MP curriculum or evolving our MP curricula, then we need some sort of measure to measure something.
Yep, thank you.
It's been a long time. I've been thinking about this for a long time.
Hi, Hillary. I'm Dr. Laura Fenimore from the University of Pittsburgh, and I teach in our DNP program as well. And you mentioned curricula, and so I wondered how your tool will inform curricula, or what recommendations you might have for faculty who are teaching NPs about role transition and what to expect.
I think a couple of things. One, I think that the more we study it in novice nurse practitioners, we can see how different components affect role transition. So having mentorship, right? So that might be something we can then encourage our students to, you know, reinforce with our students to make sure that they find a mentor, make sure they're finding a good organization to work in. If the organization really is, or if the you know, to see how much the organization impacts role transition. To look at some of the other facilitators and inhibitors of NP role transition. So my dissertation work found that formal orientation improved role transition experience, but that was, you know, a simple early study. So getting more evidence of the benefits of having an orientation or a residency program could help us guide our students. But I've been also reading some articles that maybe the role transition experience needs to start happening, and it does happen in the educational program, but maybe we need to increase or change how we're teaching students and have residency-like clinical experiences for students in the educational program to kind of launch that role transition experience. So it's not all on the employer to kind of transition our NPs, but we can start that process. And I think understanding better how that process happens and what facilitates it and what inhibits it will help guide some of the development of these kind of things within our programs to help kind of launch that transition experience.
Thanks very much.
Hi, Hillary.
Good morning.
How are you? That was wonderful. Thank you. Quick question to piggyback of what Dr. Fenimore just asked. Do you think if you had a more evenly distributed sample with DNP prepared and master's prepared NPs that you could have looked at whether there was a difference in role transition based on their degree? And do you think that a difference would even exist based on whether or not they're DNP prepared versus masters?
Yeah, I think if we had a better sample, we might be able to look at that. I hope to kind of look at that with our next efforts, and with the confirmatory factor analysis, I'd like to then do some comparisons in the sample once we kind of do some additional psychometric testing of the instrument. would there be differences? I'm not sure. On one hand, I think maybe there might be, I'm just going to hypothesize here, just from what I've been like reading. I think maybe DNP prepared MPs, they get a lot of organizational and systems level education, so that might feed into them feeling more confident, more competent, and having more of a systems look might, that broader perspective might help with the role transition experience, coming in with that higher level. The number of clinical hours are the same, so on that end, that might not make a difference, right? The patient care delivery are pretty similar between programs, so there might not be different. I don't know. I mean, it's a great question, and it's a question we should be able to answer sometime in the future.
Great, thank you.
And as we have more MPs coming out with their DNP, you know, we should be able to do that. You'd have to look at people who are brand new MPs who are coming out with a DNP versus those who've been working as an MP and then get the DNP on top of the MSN.
Right. Yeah.
It's an empirical question, and we can answer it someday.
Great, thank you.
Hey, Hillary, this is Sarah Beebe. How are you?
Fine, how are
Good
you?
to see you.
Sarah is also at GW with Asifeh Faraz Cavelli.
Yes. I'm not working under Asifeh, but I'm working under some of her colleagues. So my question to you is, you mentioned in your framework that knowledge is a big part of the role transition. And so I wonder how, have you thought about adding in any kind of the, you know, the competencies? You know, we have the AACN common APRN doctoral level competencies, but then also the new essentials have just been posted for review and comment. I'm wondering, you know, how much maybe competency and knowledge plays into that role transition, and if you've thought about aligning that with any other tool, or, I mean, because your tool is really based on the you know, the new NP's experience, but I'm curious how much also has to do with how prepared they are.
Yeah, we hadn't thought about that, or aligning it with the competencies, but that, I wonder if there's a way to use the instrument. I don't know. I wonder if there would be a way to align the two. That's a good idea to kind of consider those competencies too when studying this. Because our educational, so what I'll say is we had a few educational items. We had 5, right? And most of them, I think a couple of them fell out when I was doing the correlation matrix, so they were highly correlated, but then the rest of them kind of fell out during the exploratory factor analysis, and the only one that remained was, I am pleased with my MP education, and that ended up under sense of purpose, which we found was kind of interesting. And so a lot of those questions about feeling prepared didn't stick in, but it was just feeling pleased, like you were given the competencies to succeed. So I think one of our early questions was, my MP program gave me the competencies I needed to deliver care, or something like that. But that one fell out, and we ended up with, I am pleased with my MP education, which I think is kind of encompassing all of that. But maybe there's a way to align the instrument or a future study with the competencies.
Yeah. Because I'm finding that students are saying, "Oh, I loved my program. I can't think of anything that they didn't prepare me for." But that's also the students, or the new NP's, you know, perception of it. And I'm curious, you know, if there's more to that story. So,
yeah,
great job.
Thanks.
Are we getting into the imposter phenomena at this point in time in that first year? Is in terms of the preparedness and what their perception of, and they're not wanting to say that they don't feel like they're confident in something. because they feel like they should.
Right. Imposter syndrome emerged from my early concept analysis and a lot of the, I think some of the work that SFA did. So we didn't write any items particularly for that, but that definitely influenced some of our early items, because that's definitely what's showing up in some of the earlier research on MP role transition, is that imposter syndrome. So it's the influence of that is there within the instrument.
Thank you.
These are great questions. Thank you, everyone. This was really fun. Great way to start a Tuesday.
So we do have about 5 minutes left if there's any remaining questions. Okay. So I just want to take a quick opportunity to thank everyone for coming. This is really great turnout. Thanks so much for everyone from the University of Delaware for coming. It's really great to have you at our meetings. Just so folks know, we have one more Colloquium presentation before the end of the semester. That'll be in 2 weeks' time, Tuesday from 9 to 10 again. Actually very relevant to this conversation, we'll be hosting Ben Reynolds, who is the Chief APP Officer, so Advanced Practice Provider Officer at UPMC, and he has quite a bit of interest in this idea of role transition. He has developed a number of residency programs within UPMC to help transition new nurse practitioners and PAs into their roles, particularly in specialty areas, subspecialties like cardiology, pulmonology, orthopedics, et cetera, et cetera. So I think that'll be a nice piggyback off of what we learned today. And if anyone who's on this call from University of Delaware, we'd love to have you again. If you're interested, please email me or Amy Camadino. And Amy, if you can drop your email address into the chat, that would be great. Amy has been organizing these colloquia. So again, thank you all for joining, and hopefully we'll hear from you again. And especially thank you to Hillary for the great presentation. This was really fun. So thanks so much, everyone.
Yeah, thank you. Thanks, Grant, for the invite. This is great.
All right, thank you. And so you can see that Amy dropped email address into the chat function. So if you wanted to be on our listserv, you're welcome to shoot her an email.